But it's the spectrum. And I think my pushback to you is when you said, I'm just going to tell you about taking the class of drug, but I've been doing some more work on this notion around what's called discrete choice experiment. For patients to become more involved in saying, and we need to, it's hard to do, but it's really basically saying, look, I'm going to give you an extended number of months for an MFS or overall survival, but your trade-off is fatigue, grade 1, grade 2, grade 3, or your trade-off might be some blunting of your cognition, or the trade-off may be, GI side effects. And I think we have not done historically a good enough chance to really explain to our patients, because patients they have heterogeneity the way we have heterogeneity. You may be very aggressive, I may be more conservative in my desire to institute another line of therapy, just like some patients are very conservative or more risk-seeking in taking on certain side effects. So that's where I think the field in all of GU oncology, quite frankly, in much of what we do, we need to be better, have evidence, do the studies, do the trials like we're all participating in, but explaining these choices to patients better.
And maybe, I'm sorry to jump in, but maybe the idea is we should be tracking it better. Whether we have an educational system that tracks FACT-P or something, because one of the other problems is most of these guys, when we say, hey, how are you? They're going to say, I'm fine. And their spouse may say, not so much, because they are having some neurocognitive issues or some blunting and side effects. So maybe part of our role in doing that is we should be doing a better job tracking it.
Yeah.
I completely agree, and I think that's both in clinical practice and also in the trials, because I guess to stay on this blunting idea, things like FACT-P are actually incredibly blunt instruments to try to understand the nuances that are affecting people who are quote-unquote asymptomatic in this non-metastatic CRPC population. And what I find so frustrating is that the clinically meaningful difference, for example, for FACT-P was actually defined in a very, very different population with nmCRPC. These guys had been through things that non-metastatic CRPC patients have never experienced and won't probably experience for years. And so what's meaningful to them and the difference they're willing to tolerate could be completely different. So I think as a field, I agree with you, we do need to reassess the measure by which we are understanding these changes and really make a decision to move in a direction to be more precise.
Especially, and I agree with that, especially when these agents, we know the M0 space is sort of a space that really may not exist with emerging technology, with imaging, such as fluciclovine PET, PSMA PET, and especially also when these agents are getting moved completely to the front line, right? People actually with metastatic de novo disease, even in combination with radiation therapy in the neoadjuvant, adjuvant space. So it is very likely that our patients may actually start seeing this class of agents even upon diagnosis, right? And they stay on this class of agents for a longer period of times, right? Exposing them to significant risk.
Absolutely. So I think, as we think about this patient and really about the course that he's had, I'd love to hear kind of closing thoughts or, what are your thoughts on this patient generally on treatment of non-metastatic CRPC? Jorge.
Well, I think this case, I always believe that when a lot of people ask me, Jorge, how do you make your decisions? And a lot of people say, well, it's one feature, two features, it's the whole case. This case is more than a doubling time, in my opinion. But if I were to express, I think that doubling time is extremely important in the context of rising PSA syndrome, meaning after you fail biochemically and through the natural history of your disease. But I also want our audience to actually realize that it's not about a doubling time, it's about the entire structure behind that, his pathology, his inability to achieve an undetectable PSA, his failure early on, and perhaps even actually he may have some genomic abnormalities that we haven't even talked about yet, but that may be important for us to tap into because they may be used for therapeutic purposes down the road for this patient.
Yeah, I would agree with Jorge on all those things. I also think one of the things we didn't touch on, which I think is critically important, is really bone health and the overall health of the patient. So one of the things we try to do from the get-go once we institute ADT therapy is get them on calcium, vitamin D. We put them in an exercise program. We have a program at our multi-D tumor board back home where they can go for a consult, because I think that's important, and get them on some sort of bone health agent as well. In a lot of these clinical trials, if you look at the amount of patients who actually got bone health agents, it's shockingly low, 10, 11%. So again, I think in something like a patient like this who's not done well all the way along, it's critical to probably get this guy on bone health early on as well. So.
Absolutely, start early and
Yep.
make sure that it continues.
Yeah, that's a really good point. I mean, I think in Spartan and in Prosper, there was the use of bone health agents was about 10%. In Aramis, interestingly, was about 3%. In both arms, you know, it was balanced, and yet they had less fractures, and they actually had, you know, balanced falls. You know, I tend to, you know, in somebody who, like this patient, who appears to clearly have aggressive disease, who has good performance status, and if accessibility is not an issue, I believe in treating these patients and offering them the opportunity for therapy. And so I think, and I do believe in looking at the doubling time. It's very important. I use the Sloan Kettering calculator. It takes literally 30 seconds to put in 3 to 4 data points, and the answer is there for you. And if it's north of 10 months, way north of 10 months, I don't start therapy because, and I'll tell the patients I'll continue to follow them with PSA until they reach that point. I think this is really a good case to show the options we now have. I do think, again, gets back to us learning more about this whole issue around it's more than just fatigue. It's a lot more involved. It's more complicated. We need better validated tools, as you said. Things are now kind of blunt. And I think there's going to be some very exciting trial data that's going to be forthcoming in the near term.
Absolutely. So really just to reiterate, patient selection is key, using the PSA doubling time to help make those choices, things like Leeson score and time to recurrence also really helping us make the decision for initial ADT and then PSA doubling time again when we think about adding these agents. But at the end of the day, maintaining patient quality of life, improving it if we can, I think is going to be critical for this population, even as it evolves, as we see imaging evolve over time. And I really appreciate your thoughts on this.